requested from us to present some cases, everyday cases that we may see in our office, and to decide to see how we're going to manage them, how we're going to treat them, and decide which is the appropriate management for them. So someone gets in a 78-year-old male, comes to your office, fairly good vision with a cataract and a dry eye under treatment. The main complaint is a foreign body sensation in his left eye. He complains of irritation and scratchiness and watery eye, and he says that these kind of symptoms are intermittent in the last 3 months. Of course, you all know about this kind of condition, I suppose. It's a simple entropion. The entropion, as you know, it may be involutional, spastic, or cicatricial. If it is an involutional, we can treat it really fairly well with a lateral tarsal strip or with other modalities. However, if it's a cicatricial one, Mr. Sampath, do you have any idea, any comments on that? You just need to press that thing.
Yeah, cicatricial is very rare and usually follows some diseases like Stevens-Johnson syndrome or long-term use of topical drugs which can irritate the eye. In that situation, the treatment is more complex and you need to use something to first immunosuppress the patient just to make sure they don't have active inflammation causing the cicatrization. And of course, rule out other conditions, including the other diseases which cause mucous membrane to scar and turn the lid in. In that situation, we will need to use a mucous membrane graft or a hard palate graft from the roof of the mouth or from the back of the lip to stretch the posterior lamella of the lid and to rotate it out and maybe tighten the lid at the same time in the outer aspect, doing a canthopexy or a canthoplasty, than a lateral tarsal strip in that situation. OCP is a pretty common condition we see, ocular cicatricial pemphigoid. We work closely with the ocular surface team. They provide all the immunosuppression, and once the patient is ready for surgery, then they'll send the patient to us.
Thank you. So if the lid laxity is the problem, you may see that you can find in a patient that it may have one eye, an entropion in one eye, and entropion in the other eye. So you need to be aware of that. You can have that condition also, and then you need to treat the lid laxity.
Yeah, it's the same sort of pathology which causes both the entropion and ectropion. Ectropion is a lid turning out, entropion is a lid turning in. The orbicularis is a purse string muscle, so normally it causes entropion more often than ectropion, but depends on how the muscle overrides. If the pre-septal muscle overrides the pre-tarsal muscle, you get an entropion. If the pre-tarsal muscle falls over the pre-septal muscle, then you get an ectropion. So it's the same sort of situation where there is laxity of the lid, laxity of the inferior retractor, overriding of the muscle. So this patient is a classic example where she's got ectropion on one side and entropion on the other side. The treatment is very similar in some respects. You tighten the eyelid. In ectropion, you turn the lid in, and entropion, we do everting sutures to turn the lid out.
It's easy for us because both of them, they're Greek language, so they're Greek words, so it's ectropion and entropion. Let's go to a little bit more complex. So what about the watery eye? You have a female patient coming there, fairly good visual acuity, and complains about a watery eye, watery right eye in the last year. So what are the questions that we need to do? What are the questions that we need to ask? First of all, we need to ask if we see tears going down to the cheek. It's really important because some patients, they refer that they have watery eye, and if you ask them, do you see any tears going down to the cheek? They say, no, I just feel that they are watery. This probably indicates that there's no obstruction in the lacrimal system, and you probably have a problem somewhere else. Do you see them flow down from the medial aspect of your lid or in the lateral one? Usually this can give us an indication of what we need to go and treat. Because if it is in the medial aspect, you expect that probably there is a problem in the punctum or a nasolacrimal duct obstruction, or an obstruction of the lacrimal system, if it's in the lateral aspect, probably you have a problem in the lid. It's not 100% sure, but you are taking the history and you need to make the differential diagnosis as you proceed. Then, a very, very important question also to see if it's the same indoors and outdoors. If you feel that there is a difference, this means that probably there is no obstruction. If there is the same thing out and in, there is a mechanical obstruction somewhere, so that's why you don't find any difference.
Just to add to that, normally the lateral canthus is a little bit higher than the medial canthus, but as we get older, the lateral canthus drops. So the patient complains of watering, but it's coming from the outside. It's likely to be involutional or age-related, so the lateral canthus is dropping below the medial canthus. So in that situation, it's unlikely that the patient has a blocked nasolacrimal duct, so you would still do a sac washout, but the most likely treatment is tightening the eyelid rather than doing a DCR. And indoors and outdoors, it's a subtle blockage in the nasolacrimal duct, can produce watering when they're outdoors but not in indoors. So in that situation, the treatment maybe first port of call would be something like a nasal spray, which is Beckinase nasal spray, which is a steroid, and that can, to a large extent, can control the watering for these patients. So there's no point suggesting a surgical solution when the watering is intermittent. But when they come to a specialist clinic like ours, then we can do various tests to see whether it's a functional block or a physiological block or an anatomical block, and then take it from there. So not all watering is nasolacrimal duct blockage, not all watering needs surgery.
So last but not least, you need to be aware and ask patients if they had any lumps and bumps in their medial canthus, because they may have history of dacryocystitis cystitis in the past. So this indicates exactly that there is a problem there in the nasolacrimal duct. So what are you going to do next? So you have a patient that comes with a watery eye. Fairly easy question, probably. Are you going to check the lid position? Are you going to check the punctum? Or you're going just to do a sac washout? What do you think that we need to do? So you need to vote before we see the results, I think. Okay. All right. Okay, so most of you, they say that we need to do all the above. I think it's right. Some of you, they said only 2 and 3, which is extremely right, but we need to see the lid position also, as we said. So you need to see the punctum, you need to see to do a sac washout, but you first need to see the lid position. As we have explained previously, you may have a lid laxity, so you need to see the anatomical position of the lid, and we will explain that as the time goes on. So in her situation, of course, it's very, very obvious here. We have a punctal ectropion, so there was a sac washout would be indicating that everything is patent in the lacrimal system. The punctum probably will maybe open, maybe a little bit fibrosed, but the main issue here is the anatomical position of the lid. So when we have to make a watery eye examination, first examine the lids. We can do it fairly easily, and you can see in the first picture that the lid practically seems very, very well. The anatomical position seems really good. You don't have any ectropin, you don't have any entropin. However, when you do the snapback test, when it goes back, it doesn't really go back to the globe. This means that there is a lid laxity. And you all know that the orbicularis muscle, when it forces and closes the eyelids, the action is not practically perpendicular. It's a little bit more complex and takes the tear film and the tear lake and make it go medially. So if you have a lid laxity there, practically the orbicularis doesn't do its work. So the lid is not working properly. And maybe you have a good punctum, maybe you have a good and patent lacrimal system. Your patient will be still not very satisfied with your prescription if your prescription is only artificial tears. Okay?
Yeah, just to comment on the punctum, for the general ophthalmologist here, when you put a patient on the slit lamp, you shouldn't be able to see the punctum without everting the lid. If you're seeing the punctum without everting the lid, that means the punctum is not in good position. Punctum is everted. At the same time, the punctum, if you have in your slit lamp to measure the punctum, it should be about 0.4 or more millimeters in diameter. Younger people here should be able to see the punctum on eversion without needing glasses, but people beyond the age of 45, maybe we need some help. But you should be able to see the punctum without magnification, which means you can assume that punctum is of normal size. If you're not able to see the punctum with naked eye, then that is stenosed. When the punctum is not against the eyeball, when the tears is not flowing across the punctum dries and stenoses. So once you put the punctum back onto the tear lake, by whatever surgical means, the punctum automatically opens up. So you don't need to do a punctoplasty in a patient whose punctum is everted. That means it's dry, it constricts when it's dry. So do not diagnose punctal stenosis when the punctum has not been against the tear lake for a long time.
Thank you. And as doctors, we like grading system. Here you can see a grading system for the medial canthal tendon laxity. So it's very good to do these two tests when you see a patient with a watery eye before starting doing after your history. Okay? So as we have seen until now, we need to do an averted upper eyelid also to see if there is any pathology underneath. We need to see the position of the punctum and its diameter. We need to find out if there is any eyelashes problem. It's very important to get a good view of the tear lake. If we see debris in the tear lake, this means that probably there is a problem in the lacrimal sac, and we see the debris going out of the canaliculus. We need, of course, to evaluate the breakup time. It's really important because we may have a patient with a watery eye that just secretes more tears. You all know, we all know that, and we just treat him with artificial tears. The dye disappearance test is a really nice test. We need to put 2% fluorescein, plain fluorescein, in both eyes, and then we can see if there is a disappearance of the dye in the next 5 minutes. If we see that, this means that the lacrimal system probably is patent without doing a sac washout. And of course, the sac washout is the main tool that we have to diagnose if there is any obstruction in the lacrimal system. Last but not least, before you proceed with any operation in the nasolacrimal lacrimal system, it's good to do a nasal examination with endoscopy, because otherwise you may end up having troubles.
Yeah, just as insisted, top of the list is everting the upper lid. So it's always very, very useful to evert the upper lid in any patient with a watery eye. So they could have allergic disease. You can see a lot of papillae. Even in specialist clinics, sometimes people forget to evert the upper lid. There are a lot of clues in the upper lid when you evert. So everting the upper lid, having a good look in any ocular surface condition is extremely helpful. So that could be ptosis, that could be irritable sore eyes, that could be blepharitis, that could be watery eyes. Always we insist on everting the upper lid and having a good look.
Very good. And then we go to do the sac washout. And there is a problem. There was always a problem, and when I was a trainee there was a big problem, about a soft and a hard stop. It is usually a very big problem when you do it first time and you don't know, is this a hard stop? Is this a soft stop? Because probably it can indicate that you're going to do a different treatment between these two conditions. So I think that one good indication when you have a soft stop is that you see the lead moving with your cannula. If you don't see the lead moving with your cannula and you find the end of the pathway, then you probably have a hard stop. If you see the lead moving and you have a problem there when your cannula goes into the lacrimal, into the punctum and to the canaliculus, then you probably have a stenosis or an occlusion in your canaliculus. So let's say you're in your office, you're waiting for your next patient. He comes in, 28 years old, 6/6 vision in both eyes, And what he says is that he has a left watery eye in the last 2 years. Okay? He had an episode of conjunctivitis, this was what he remembered, and after about 2 or 3 months he started having an intermittent watery eye, and then it became constant. Of course, to make things a little bit worse, he has a past surgical history of a septoplasty because he had a problem in his nose. And he's very, very anxious. So, in the clinical examination, you say, okay, I have seen a doctor there in Thessaloniki. He said, first look the lids. You look the lids, but he's 28 years old. He has a good anatomical position. Punctum, it's small, but fairly open and in a good anatomical position as well. And everything else seems to be more or less normal. And then you go to do the sac washout. And in the sac washout, in the right side, you can find a hard stop, while in the left side, you find a soft stop, a proximal soft stop. So, you're wondering, what am I going to do with this one? What do you think? These are the options. You may think about, okay, maybe his lids are tight, but I'm going to make them tighter. It's an option. You may think, okay, I have a small lacrimal obstruction there, so I will do a 3-snip punctoplasty, a little bit bigger, to take out the whole obstruction, or maybe proceed a DCR and make an opening. I may put a Leicester-Jones tube, or you don't do anything and I will just prescribe artificial tears. So, do you want to tell us what you think that you're going to do? Okay, so, Mr. Sampath, do you want to comment?
So, what's the highest vortex?
No. You can stay.
Don't worry. Okay.
No, don't worry.
Right. See, when there is a soft stop can be caused by various conditions. Soft stop is a term used when you, as he explained, when you put a sac washout cannula, and the cannula doesn't pass into the lacrimal sac, but stays within the cannula. And when you try to push, it will take the lid with it. So that tells you that there is a soft stop. This can be caused by herpes simplex virus. That's the commonest, herpes simplex conjunctivitis. Commonest cause of canalicular scarring and soft stop. And it can be caused by various other conditions, including some of the medications used for anti-cancer drugs used for ovarian carcinoma. Many of the drops which we use, including our humble timolol, can cause canalicular scarring, and wrongly done sac washout can cause canalicular scarring. So a lot of things can cause canalicular scarring and soft stop. If a young patient with a soft stop and there is no fluid going at all, then you don't have much choice if the patient is very symptomatic other than to do a Leicester-Jones tube type of procedure where you do a DCR, usually endoscopically, and then put a glass bypass tube between the medial canthus and the nasal cavity. No other procedure is going to work in this patient. If the canalicular block is very close to the common canaliculus, very close to the sac, then one can do an external DCR type of procedure and excise the scar and do the normal DCR and put some stents in. But if the canalicular block is very proximal, more close to the punctum than closer to the nasal cavity, then you will need to do a bypass tube like a Leicester-Jones tube. There's no other option. Other options, if the patient is not keen for surgery, you can inject Botox into the lacrimal gland to reduce the tear production. But that's a solution which we normally do not use when there is an obvious anatomical block. Sometimes we use that solution when there is a functional block or a physiological block. What I mean by that is patient has watering, all the tests are normal, your sac washout is normal, you've given them Beckonase, etc. for a month, but still they have watering. what do you do? Then we do a test called a scintillogram, which we put drops of radioactive dye and then that's tracked down. If there is an obvious block in the scintillogram, then we do as if there is an anatomical block. If there is no block on scintillogram, but still they have watering, what do you do? Do you suggest a DCR? Do you suggest a Becquerel spray? Or do you inject Botox into the lacrimal gland to reduce the production? So these are all the options you need to discuss with the patient. No option is straightforward.
Thank you. So this is the Leicester-Jones tube, practically the first one. Is the Pyrex tube that bypasses everything. These are the perforated puglar plugs. You can use them when you have a punctal stenosis, or you can use a mini Monaca stents when you have a canalicular obstruction. Of course, we have seen all the other treatment modalities. And when you have a lid laxity that it doesn't, that you have already performed, can we just stop that a little bit? Thank you. So when you have a lid laxity, you have already performed surgery and you see that it doesn't work, then you can redo the same thing or you can do something new. So we have Mr. Sampath here who has practically invented this technique, and we will see a short video of that, and then we can proceed with the rest of the presentation.
No, this is a procedure done for extreme cases of lateral canthus rounding, where the lateral canthus is pulled towards the medial canthus. Normally seen in patients who had repeated procedures to tighten the lid, and by patients, especially in the cosmetic world, where patients complain after surgery, they are not happy. The surgeon goes in, does the same thing again, tightening the lid, but the pull is always towards the medial canthus. So the lateral canthus eventually travels towards the medial canthus if you keep on shortening the lid. So these patients are quite unhappy, and you can't go in and again try to attach the lid to the lateral orbital wall periosteum, because it's not going to work. As there's a famous saying, if you repeat the same procedure, expect the same result. Don't expect a different result by repeating the same procedure. So we thought about this, and we have devised a procedure where we drill holes into the lateral orbital wall and then attach the lateral canthus.
The lateral canthal tendon is the tendon of the origin of the pretarsal muscle. It arises from Whitnall's tubercle, which lies 2 millimeters posterior to the lateral orbital rim. Lateral canthal tendon dehiscence or laxity may be due to aging, trauma, previous surgery, or rarely congenital causes. When any of these mechanisms take place, the lateral canthal tendon is detached from its anatomical position due to 2 vectors: horizontal pull from the medial canthal tendon and vertical pull from gravity. In these cases, simple upward and posterior displacement allows the lateral canthus to be fixed in a more anatomical position. Lateral canthoplasty is a surgical procedure commonly used to fix the lateral canthal tendon in place. This video will demonstrate a technique that facilitates transosseous fixation of the lateral canthal tendon. An initial skin crease incision is made. Insert the desma retractor and open the periosteum using monopolar to access the bone. Lift the periosteum using the Freer periosteal elevator. Check and then mark the level for drilling. Position the retractor to protect the globe and then drill 2 holes into the lateral orbital rim.
Keep in mind that this is only for extreme cases, right?
Use
They have done multiple
fibroproline to
surgeries
grasp
and they have
the
failed.
lateral canthal tendon.
Non-absorbable suture for this. This is not a commonly done procedure. Even in our tertiary practice, maybe we do 2 patients a year with this extreme condition, which we've exhausted all other techniques.
Recheck the level to ensure good cosmesis. Now create the lasso suture using 4O silk.
So you create a lasso and pass it through the
lasso
hole.
can be passed through one of the drilled holes more easily than a proline suture and more safely than a needle.
This publication and video is available on the OPRS site. People
Now open the flexible silk lasso and pass through the 5O proline stitch which had previously been hit through the lateral canthus, as shown. Allowing the silk lasso to then grasp the proline stitch, pull it through the drilled hole twice, one after the other. Use blunt probing to check the drilled holes.
So once the suturing is done, we can fast forward it, and it'll get too boring for the non-oculoplastic specialists here. Sorry. So that's what you do. So you pass both the sutures through the 2 holes and tighten it on the outside, and the whole lid is dragged. Can you fast forward it a bit? Just to show the pre and post-op pictures, that'll be fine now. So basically, you pass those 2 sutures through the holes and then tighten it. Can you take it forward, please, a bit?
Finally, tie the
No.
5O proline to anchor the lateral canthal tendon to the lateral orbital bone. This technique demonstrates a convenient and safe method for transosseous fixation. These pictures illustrate that using this simple technique, one can achieve optimal aesthetics. The Leicester lasso concept is...
Right, so we can do this under local anesthetic with good injection on the lateral side of the orbit and in the upper and lower lids. So it can be used under local, no problems at all. Right, so moving on to ptosis, which is quite a common problem, as you can see here with the patient. So this patient has normally in the European and Asian, that is not Chinese, race, you should have a skin crease, okay? In the Chinese race, they don't have a skin crease. So if there is no skin crease, then you start thinking what's going on there. If there's a ptosis and no skin crease, then it's likely to be dehiscence or the upper neurosis to the lid, which is usually, the term used is involutional, not senile anymore, because as we are all getting older, we don't want to be called senile. So it used to be commonly used before, so now we use the term involutional. So you can see that there is no skin crease and the lid is droopy. So that gives you a clue on what's going on here. So these are all the findings. Margin reflex distance is the right thing to do when you're checking palpable aperture. So palpable aperture, normally you wouldn't see a scleral show, but some patients are born with a scleral show because of shallow orbits or what's called a malar hypoplasia. But if you see a scleral show, it's an important sign for general ophthalmologists, especially if there was no scleral show before. On one side, you see the scleral show inferiorly. That's an early sign of proptosis of the globe. So scleral show inferiorly is an early sign of proptosis. So if you see a new scleral show in a patient, do think of proptosis. It could be the lid being dragged down for whatever reason, but inferior scleral show is a useful sign for early proptosis for non-specialist ophthalmologists who don't deal with proptosis day in and day out. So, but this patient's scleral show is because of age-related or involutional, but margin reflex distance is what we use when the lower lid is dragged down. So you can see the corneal reflex there. You check that distance. Here you have to lift the lid to check that, which means it's negative margin reflex distance than normal margin reflex distance. So you can see all the, another thing you can see is when you stretch the lid, you can actually see the scleral, the iris pigmentation change through the lid, through the cornea. So you can, if it's very stretched, there's nothing left between the conjunctiva and the eyelid skin. Everything is retracted, the aponeurosis is dehisced. So that's a useful sign when we show to young doctors that you can actually see the iris pigmentation through the lid. Of course, there are various types of ptosis. The commonest one we see is involutional ptosis. It can happen due to age. It can happen to repeated drops, especially long-term steroid drops, can produce involutional ptosis. Contact lens wearers, long-term contact lens wearers can produce involutional ptosis. So it's not just age. And of course, there are other types of ptosis which we are all concerned about, which we will talk a little bit in a minute. Right. This is a useful patient to look at, okay? I don't know, I'm sure you can see from a distance, she's got a left-sided ptosis. Agreed? She's got a pupil there which is of normal size. This pupil appears a little bit smaller. Please take it from me. If you're not able to see it, the pupil on that side is a little bit smaller than the other side. Okay? And the ocular movements are full and no diplopia. We need to look at two things here. One, you want to know whether there's headache. If there is severe headache and sudden onset of ptosis and miosis, you can think of one thing which everybody will come up with the answer, but the pupil is dilated. We all know third nerve palsy, sudden onset of posterior communicating artery aneurysm rupture causing ptosis, dilated pupil maybe, but reduced ocular movements. Severe headache, which people, many general ophthalmologists may be unaware that severe headache, mild ptosis, small pupil, internal carotid artery dissection. We see about 1 to 2 patients a year who present to us with severe headache, ptosis, small pupil. It's a medical emergency. Internal carotid artery dissection can produce exactly the same symptoms like an acute third nerve palsy. So but this patient had neck surgery before, so that gives us a clue of what went on. So she has Horner syndrome, okay? There are various tests, but mainly it's a clinical diagnosis. And if it's severe headache, then you need to do an urgent MRA, angiogram, whatever is appropriate, whatever is available in your center. But do think of internal carotid artery dissection in a sudden onset ptosis with a small pupil on that side. Right, there are other conditions which can produce ptosis. So this patient has bilateral ptosis, but she has symmetrical reduced ocular movements. Okay? If it is symmetrically reduced ocular movements with the ptosis, think of a condition called CPEO, chronic progressive external ophthalmoplegia, which is not an uncommon condition. They don't get diplopia because they've got symmetrical reduction of ocular movements. So in this patient, you usually do a muscle biopsy. It's a mitochondrial disease, so the fresh muscle biopsy helps in the diagnosis. Right. So I've given the answer here by mistake.
Yes.
So we'll skip that question.
That's good.
That's my fault. I'm sorry. Right. So if you have a patient who has ptosis but asymmetrical reduction of ocular movements, okay? think of myasthenia. Okay. Myasthenia, unfortunately, presents to the oculoplastic surgeon many times because we are the first ones to pick them up. Fatigability, but they have asymmetrical reduction of ocular movements. It could be ocular myasthenia or systemic myasthenia. In ocular myasthenia, unfortunately, all the blood tests you can do underneath the sun doesn't come back as positive. So it's more a clinical diagnosis of fatigability and a very useful test called an ice test, where you put some ice onto the eyelid for 5 minutes usually, but we do it for 2 minutes because it gets very painful after 2 minutes, and the lid becomes normal. That's because the neuromuscular junction, the acetylcholine receptors and the acetylcholine, there is an anti-receptor antibody in the patient destroying the receptors. So the acetylcholine, whatever is produced by the muscle endpoint, is not by the neuromuscular junction, is not able to lift the lid. By putting ice in, you reduce the breakdown of acetylcholine and increase the concentration of acetylcholine in the neuromuscular junction, making the lid go up. So it's a very useful clinical test to rule out myasthenia in a patient who comes with variable ptosis, getting worse towards the evening, maybe with asymmetrical reduction of eye movements on both sides with diplopia. We have had patients who have come in and had diplopia, ptosis, and unable to eat after a while because the jaw muscles go into paralysis after they've used it for some time. So you may be the port of call for a very important condition diagnosis.
So yeah, the ice test has a very, very good specificity, and it's been there in many papers. I wanted to add also about the globe position. It's really important to keep an eye on the globe position. You may have a proptosis, but you may have an ophthalmos or hypophthalmos. So you may have a pseudotosis, and you may be aware of you may not be aware of a problem in the orbit that causes a pseudotosis. And for example, if you have a middle-aged woman with a history of breast cancer, you need to think about that. It creates an anophthalmos, and it can create. We have many referrals like that. Not many, but we have enough.
Right, I think where the first BOPS meeting, inaugural BOPS meeting, our then fellow got the prize for putting a series of inophthalmos secondary to breast cancer. Second, we have had, in the last 17 years, I've been in Leicester, we've had about 5 patients presenting to us with breast carcinoma secondary in the orbit. Out of the 5, 2 were primary presentation. No history of previous breast carcinoma, but presented to the eye service with reduced ocular movements and enophthalmos. They get enophthalmos, not proptosis when they have secondary Ascaris carcinoma. In women with enophthalmos, breast carcinoma is top of the list. In men with enophthalmos, lung carcinoma is top of the list. And GIT carcinomas, that is from the abdominal, either small or large intestine carcinomas, or even in both women and men, but breast carcinoma in women and lung carcinoma in men, causing enophthalmos, reduced ocular movements, and really hard orbit. So when you see a patient, just push your fingers in, hands and sort of bounce the globe within the orbit. If it's a secondary, it will really be very hard. So that gives a clue. Right, moving on to eyelid lesions next. You can see telangiectasia and certain changes here. We will go through it in a minute. And another patient with an eyelid lesion. You can see what's going on there. Another one with an eyelid lesion, not operated before, coming like this, with all the signs. We'll talk about the signs in a minute. Another patient, again, all the typical signs. We will talk about the signs, but look at the lid, how it is. That's not normal blepharitis. That is not Calasian. That is something sinister. Another one, unilateral blepharoconjunctivitis. Be very careful. Unilateral ones especially. Blepharoconjunctivitis, send it to the enemy you don't like. They are difficult to treat. They are unhappy patients. Whatever you do, whatever you give them, they are still not very happy. But unilateral blepharoconjunctivitis, you need to be very careful because it could be something sinister. We'll talk about it in a minute. Another thing, you may think, what are all the role of Botox? There's the paper which I haven't yet started using Botox for chronic blepharoconjunctivitis. So there was a presentation in ASOPA's meeting a couple of years ago when they used Botox for chronic blepharoconjunctivitis. Their theory was it reduces the stimulation of the meibomian glands to produce meibomian secretion. So the Botox reduces the secretion of meibomian glands. I haven't tried it yet, but it's out there too for chronic blepharoconjunctivitis. Right, so you saw the various ways the tumor was presenting. So loss of eyelashes is an important sign. You saw the destruction of lid margin. You saw ulceration. You saw pearly edges. And obviously, if the tarsal plate is involved, recurrent chalasia, be very careful. Say you have done the first surgery and you're pretty certain you've taken everything out. Still happens sometimes, even in the best of hands. But if it keeps on coming back and the patient is over the age of 50, do start thinking and sending it for histopathology the second or third time you're doing it, because sebaceous gland carcinoma can present as unilateral blepharoconjunctivitis, can present as blepharitis, can present as recurrent chalasian. Sebaceous gland carcinoma we need to be concerned about, so be careful. Right, so here is a patient who you think may have a little scar, may have an injury, may have previous DCR surgery, may have had dacryocystitis, a ruptured and produced a scar. So he is all that says, everything. Watery eye, okay. Lesion in the medial canthus.
Practically, he came to our department for a watery eye.
Yeah.
The referral was a watery eye.
Yes,
in the
and
last
if you
year.
look at it, he's got, you can't see the punctum, the lid is turned out, okay? So you could think it's an ectropion, but there's something wrong there. So you can see all the signs of what looks like infiltrative lesion. No history of surgery before, no history of trauma, no history of bleed, no history of previous dacryocystitis. But if you ask carefully, they'll say it scabs over, I scratch it off, it bleeds a tiny bit, and it settles. So this is the typical history. So what would you do in this situation? Audience, I will not give out any answers this time. Right, what is your next step? Excisional biopsy, 3 millimeter margin, excisional biopsy, 10 millimeter margin. Would you imagine, do a MRI or CT scan, or you would just see the patient every 6 months? Can we go to the... Oh, inject Avastin, yeah. Or do an OCT, why not? How can we see a patient without an OCT? I don't know. There are some OCTs for lid margins as well. I don't want to bore you with that under punctum, but anyway, that's a different thing. So.
Yes,
no,
yes.
We always do a...
Yes, it was dilated, yes.
Because we'll tell you why. Most patients with any visual problems, we dilate and have a look. Yeah.
Has to be ready to refer them to VR or to make it ready.
Right. Yep. Right. Okay. Imaging the orbits. Perfect. That's a correct answer. And then normally when we are suspecting a BCC, we'll go for a 3 millimeter margin. If you're suspecting a melanoma, we go for a 5 millimeter margin. If you're suspecting a sebaceous gland carcinoma, we go for a 5 millimeter margin, and we do a pagetoid spread biopsies for map biopsies of the conjunctiva, but we'll move on.
Can we go in the previous one? Because in the first image of the patient, because all of you have put the margins and everything, which could be right, but if you see the whole face, you will understand that there is a problem in the right hemiface, practically. We can go to the previous one, please. Yeah. So if you see the whole hemiface here is dragged up. There is a huge lesion underneath. That's why the correct answer would be to make imaging. You need to think about the whole, not only about the lesion. You may miss that, and then you will end up making more and more. Okay.
For the general audience, you may not know there are multiple types of BCCs. The worst type of BCC is called a cicatrizing BCC or a morphiform type BCC, which can spread underneath the skin, cause the cicatrization, and it behaves much worse than a cystic BCC. So there is a cystic, there are 4 types of BCC. I don't want to bore you, but if it is cicatrized, it carries a worse prognosis, needs more aggressive surgery. If it is a nodular cystic BCC, it behaves better, and surgery is usually not as aggressive. So we looked into this. So the images were done, and you can see that it's spreading down, and I can tell you it was spreading quite deep into the side of the nose, into the nasolacrimal duct. So we had a head and neck discussion. All our tumors are discussed, and we did a combined procedure with the ENT surgeon. We did excision in stages. So we thought we'll try to preserve the globe. So we did a huge excision first, but unfortunately that came back as positive, spreading deep into the orbit. So again, went back and rediscussed in the MDT, and it was decided that the best course of action to stop it spreading to the cavernous sinus. Once it spreads to the cavernous sinus, unfortunately, the treatment choices are very limited. So the choices for treating an extensive BCC like this are either surgical excision or radiotherapy, or there are newer drugs for multiple BCCs or Gorlin syndrome, etc. But this particular patient, it was decided surgical excision was the best course of action, and he was also keen to get rid of it as much as possible surgically than any other way. Okay, and that's him after the exentration, and that's a flap from the median forehead. Again, to talk about Greek civilization and the Indus Valley civilization, which is predate to BC. And this original flap was described 200 BC by an Indus Valley surgeon called Sushruta. It's all there on the net. And those days, I believe, chopping the nose was common for infidelity. But I don't know, even then they were sexist. They only chopped the nose of women, not of men. We know which part to be chopped for men if it was infidelity, but anyway. So they used to chop the nose, and he devised a procedure using a median forehead flap to reform the nose, and he used bamboo shoots for the nostril, and I believe he was very busy. So infidelity is not new. Right, there's another patient with, again with a cicatricial ectropion, and there was something not right there. So we did an incisional biopsy, and we did a CT scan, which showed this is spread into the orbit, deep into the orbit. So again, discussed, had exentration. And they do quite well with good rehabilitation. You can hardly say that she's, obviously it doesn't move, but looking in primary position, they get pretty good results. Next, to just wake you up, this patient, I treated personally, was pushing the car up the ramp. The car rolled back, and the exhaust pipe basically trephined the right orbit. Unfortunately, it had gone through the optic nerve, but all limited to the orbit, nothing intracranial. So we spent hours fixing everything. She had a good cosmetic result, but obviously no vision in that eye. So next, looking into a case, a 10-year-old boy. All the everything as suggested. I will not go through. I will not give you answers again.
No. But he just been referred to us 12 hours. He had a road traffic accident 12 hours ago, and he sent to us by an E&E. He just they said just take a look of him. He didn't have much of it. As you can see here, unfortunately we don't have a picture. Only a small chemosis in the lower eyelid and a small subconjunctival hemorrhage. Nothing more than that. But there was a restriction in his left eye, and there was pain and nausea during the upgates. So, these are the images.
Okay,
They're
you can
clear.
see all the signs here. Oh, sorry, press the wrong one. Can we go back, please? Right, so here you can see that's the right orbit, that's the floor, and here you can see there is something gone on there. There's a little break. There's some tissue from the orbit prolapsed into the maxillary antrum, and you can see it's not a large fracture, but it's a fracture, but with ocular movement problem, which Vangelis has already mentioned. Okay, what would you do here? Just monitor, operate within a month, operate within a week, operate within 48 hours. How old was he, Vangelis?
10 years old.
10 years old, so that has a clue. So any answers, please? Right. Good. Sorry, go back for me. Go back again. Go back one slide. Right. So basically, the orbital fractures are a very complex area. So I don't want to give you, I can talk half a day on it without stopping. The children in orbital fractures with diplopia need, if you can see a fracture, good, you need to operate on them as soon as possible. They are called white eye fractures because they don't have much other signs other than restricted eye movements. If you don't operate on them very quickly, they get permanent fibrosis and it will be very disabling for the rest of their life. Even if you can't see a fracture on the scan, but still they have reduced ocular movements, a forced duction test if necessary, do it under GA, and then go in and search for a fracture. These are like green stick fractures. They fracture and flap back, and then tissue is held within the two parts. And it's not big enough to be seen on the scans, but clinically they have reduced ocular movements. Forced duction test shows you there is restriction. It's a white eye, and you have to, in this case, do a EUA, do a search for the fracture in the floor, and then correct it. Because it may just be a little flap which is holding, a sheath of the muscle is being held within the two flaps of the bone. It's a green stick fracture. It can be missed on the scan, can be missed clinically, but you have to do a forced duction test and correct it if necessary. I'm sure you're squint experts here who know more about dealing with this if it becomes permanent later in children in fibrosis. In adults, it's a different ball game. There are various criteria, enophthalmos of more than 3 millimeters, hypophthalmos, where the eyeball comes down of more than 2 millimeters, diplopia on looking down, diplopia on looking up only if it interferes with your work. If you're Michelangelo painting the ceiling, then a small diplopia, or if you're a snooker player, small diplopia and elevation may be an indication. But these are all the indications. And there could be another indication, which again can be missed, is oculocardiac reflex. When they have a little fracture and the bone is held, when they move their eye up and down, they can feel sick. The same thing which you see in oculocardiac reflex when you do eye surgeries can happen with a fracture. So these are all the sort of indications to interfere in a fracture. Not all fractures need surgery, and all the adult fractures can wait for a month before you do surgery. You can do serial testing, orthoptic assessment to see whether their diplopia is a temporary one or a permanent one because of the fracture. So not all fractures need surgery, but in children, they need emergency or urgent interference compared to adults. Thyroid eye disease, another huge area where we spend a lot of time on thyroid patients. We got a huge number of thyroid patients. We run a tertiary referral center, and we do the third largest number of decompressions in the United Kingdom. And these are typical features. So you can see the patient presenting with, you can see the signs of inflammation in one eye that suggests it's an active disease. There are various grading systems one can use. But grading system is useful to see repeatedly, but is it useful for an individual patient sitting in front of you? Not entirely sure. So what would you do in a patient like this? Would you just monitor? Would you start treatment with oral prednisolone? Would you start treatment with IV methylprednisolone? Or would you use artificial teardrops? Here is a patient, you saw the picture, quite an active disease, significant inflammation on the ocular surface, significant chemosis, significant lid edema. You can see she's already tearing, very active disease. What would you do? The various things you would do in addition to what is said there, but at least this is a clue. Right, okay. There are various, again, thyroid eye disease, we can talk for a week on it and never come to a conclusion. So there are various thyroid meetings I go in confused, I come out confused. So there is no easy management of active thyroid eye disease. It's not like a cataract. Cataract, do surgery. OCT, ARMD, inject. But thyroid eye disease is not like that, I'm afraid. Active disease, there are various treatments one can give. So obviously they need an assessment. If there are various trigger factors, so you should look for the trigger factors. Are they a smoker? Cutting smoking can reduce the activity. Is their thyroid function yo-yoing? So every time thyroid function yo-yos, their eye disease gets worse. Any sudden severe stress in life, like bereavement, death, loss of job, divorce, all of that can produce sudden severe activity in the eye disease. Ongoing other inflammations, infections, could be urinary infection, could be chest infection, all that can produce activity. So you look for the trigger factors, control the trigger factors, control the thyroid functions, etc. But patient is sitting in front of you with quite significant disease. What do? Then obviously you do an MR or CT, whatever your unit is happy with. Normally, IV methylprednisolone is the first port of call for active disease. We divide the patients into 3 types: mild, moderate, severe, active or inactive, progressive or non-progressive. So when a fellow comes to you and says, this patient has thyroid disease, I want to know, is it mild, moderate, or severe? Is it active or inactive? Is it progressive or non-progressive? Based on this, you decide the mode of action. That patient I would classify as severe and active, and they get IV methylprednisolone, and then regularly seen, and then you decide whether you go for further immunosuppression, non-steroidal immunosuppression, one of these wonderful new drugs like rituximab, and another one, tetra. I can't even spell some of the names and pronounce some of the names of the new drugs. We work with the immunologist, but there is no one treatment here which is going to cure the problem. So there is immunosuppression with steroids, non-steroidal immunosuppression like azathioprine, mycophenolate, newer anti-TNF alpha drugs, and anti-fibroblast drugs. All of them are there. Radiotherapy. There are many things in the air for thyroid eye disease, active treatment. You need to sit down with the patient, discuss all the options, and again give her a confused solution. I could do this, I could do that, but not like an OCT and injection. So, yes. Okay, good. We'll just... Thyroid eye disease can also present as a white eye. Here is a patient with no proptosis, but with a visual field reduced on one side. So I'll just go through the slides and then... No proptosis, okay? Again, visual field reduced on one side, suggesting optic nerve compression or glaucoma. It was sent from casualty with a reduced visual field because the optometrist has sent the patient there. So you can see here all the signs. All the signs of thyroid muscle enlargement, both sides. Thyroid, always there's enlargement on both sides, asymmetrical. If it is one side and doesn't involve the inferior rectus, you need to think of other conditions like lymphoma in the muscle. Sorry, I'm digressing. He wanted me to keep it simple, but more you see, less you're confident. So not every patient who walks in with a proptosis and a scan which shows enlarged muscle is a thyroid eye disease. They could have something very serious. We did a biopsy last week, it was a mucoendocrine carcinoma presenting as an enlarged muscle like a thyroid eye disease, referred as a thyroid eye disease. So there are variations. So she fitted into a thyroid eye disease. She doesn't have any activity, so there's no point subjecting her to IV methylprednisolone radiotherapy. If it is active, you treat with immunosuppression. If it is not active, it's called white eye thyroid eye disease. So she had a small decompression, posterior medial decompression, and you can see the visual field, pre-op, post-op, within a week after surgery. So there are various grading systems which I'm not going to bore you. I'll talk a little bit on one or two patients. Patient comes with ptosis of the upper lid in this particular patient. Right, here is a patient, what looks like bilateral ptosis, okay? But look at the upper lids, there is some fullness, okay? What would you do? Would you just go in and operate? Would you monitor, or would you do something more? You just got me going. Right, results, please. Right, so if a patient comes into an Orbit clinic, first thing we do is request a scan. Okay, so like you would request an OCT for anything in the central vision, we will request a scan. And we get told off by the radiologist, you don't order a scan, you request a scan. So this patient had bilateral lacrimal gland enlargement. We published this as a report in OPRS journal, bilateral lacrimal gland enlargement. He had post-transplant lymphopoietic disorder, which is like a lymphoma. He had a renal transplant, and renal transplant patients who have immunosuppression get all forms of carcinomas in and around the eye and the orbit. They have 40 times more risk of developing squamous cell carcinoma in the lid. They get lymphomas, they get various tumors around the eye. If you have a patient with renal transplant on immunosuppression or any transplant on immunosuppression, be careful. These patients may have hidden carcinomas around the eyes when they come for ptosis, when they come for proptosis, when they have lid lumps. So just looking at the various, this is again bilateral sort of fullness in the upper lids, but a scan shows huge enlargement. You can see the lacrimal gland is enlarged so much, but they don't have much of a proptosis. So orbit is a very nice structure. So it can hide large tumors and giving you only small clues. Okay, so you need to be careful. Look for the inferior scleral show. Look for the fullness in the upper lid. Those things give you clues. IgG4 is a condition which we are recognizing more and more. This is a pleomorphic adenoma taken out. This is another pleomorphic adenoma which works differently than the rest. You can see how it is. It's a usually history of 1 year with slow growing proptosis. I think I'll not bore you with questions this time. Basically, pleomorphic adenoma needs an excision biopsy, not an incisional biopsy. You are doing a disservice to the patient by doing an incisional biopsy if you're suspecting a pleomorphic adenoma. Adenoid cystic carcinoma, again, is a killer disease. You need to be very careful with these patients. And here is a patient with reduced ocular movements. Okay, small amount of proptosis, reduced ocular movements, and clue is in the scan, there is calcification, which I'll point out, okay? Some calcific spots, and already it has spread to the cavernous sinus. So unfortunately, this patient is no longer with us. A little bit of cosmetic blepharoplasty, which is part of our private practice, which we work with Theo. He makes me work very hard so that he can put his feet up. For one injection, he gets paid more than me for doing blepharoplasty, but that's a different ballgame. Right?
We have to invite you once a month, rather months like that, on the Friday, the first Friday of the month. We've got an NVT meeting, so we discuss all see a football game as well. He's like that once a month, but we have to make a stop. So
Okay, thank you. So just giving you cosmetic bleph, and that's part of our practice. Thank you all very much.
Thank you so much. Fascinating talk. I absolutely admire Raghavan because he has everything so clear in his head and gives so much information, so educational. And he has everything so clear and he has the answers with the percentages, with what can happen and so on and so forth. Very, very quick, 1 or 2 questions if you have any, but we have delayed massively the colleagues for the next session.
Any couple of questions, please? 2 questions.
Thank you very much. Thank you, guys.
Sorry for having you.